Look, one of the original ideas in terms of having this panel discussion was really to discuss ways in terms of how various places are doing things in terms around trying to achieve access for all. As Sam kind of illustrated, I think I was sort of gazumped by the Pan-Canadian Pharmaceutical Alliance announcement last week, which was incredibly exciting in terms of the deals that have been negotiated with the pharmaceutical. Now, again, like Sam said, we don't know exactly what those deals are and whatnot, but what I think was really important was that both British Columbia and Ontario then made announcements as part of a news release that they'll be offering access for all starting 2018. So I think this discussion perhaps maybe shifts a little bit around, okay, we've got access for all, and what are some of the components that might be needed to get there? And so Greg's discussed a little bit. I'll go back to the GP prescribing issue in a second, but the first thing I wanted to sort of ask is to Jean-Michel. Look, Australia is one model. It's not the only model. And I'm really interested to hear from you, Jean-Michel. France had a slightly different strategy in terms of how it did its pricing, and I just wanted maybe if you could explain a little bit about how that happened. What were some of the components that led to the success in terms of bringing together the stakeholders, and what that model looks like a little bit?
Okay, so I was listening to Greg very carefully, and I saw there are similarities and there are differences as well, and obviously every country has its model, and probably the lesson we can draw from our discussion today that there is not just one model, and different ways by which you can achieve your goal, which has been called elimination. I may treat this issue to start. I don't believe in elimination. I understand it's a very good slogan, it's a very good political word. We will eliminate, we will kill, we'll whatever, but at the end what we're aiming at is control of that infection, make a frequent infection a rare disease, and that will be great if you can achieve it. And I think we can probably agree between us on this, and then when we try to raise money for this goal, we can call elimination and speak to politicians who don't understand anything anyway. So that was the preliminary point. On your question on the strategy, France started with its first national program in 2001, and it was a very heavy campaign to raise awareness and screen people, and it was pretty successful. After 3 years, we had identified nearly 60% of the estimated number of patients who were infected in the country. And then this number raised slowly year after year, and now we are approximately at 75%. But what I notice is that we don't see the 25%, the ones that are missing. We don't see them. We should see them. Everybody goes to the hospital at some point. Everybody goes to a doctor. We see new patients. We see new cases, but not the 25%, which the government is desperately seeking for. And my hypothesis is that maybe they do not exist. Maybe the estimates, maybe the modeling was wrong, and we have identified the vast majority of our patients, and you have to realize that any modeling is based on assumptions that may be true or not true, and maybe these patients are not missing. So I would tend to think that we have identified the vast majority of our patients, and we have treated a substantial number. So in terms of strategy, the initial strategy was like everywhere when the new DAs arrived, was to prioritize patients. And I think the term prioritize has not been well understood by many people, including ourselves. It was understood as denying therapy for some people who would never be treated. I think it's never been thought, and our politicians are stupid, like any politician, but not that stupid. And they knew that at some point they would have to treat everybody. They just wanted to give access to therapies, the most difficult to cure patients, the most advanced diseases, with the ridiculous price they had for these drugs. So talking about negotiation of the price, I totally agree with Sam's comment. We have no clue as to what the real price is. We have official prices, but we have no information on the negotiation, and neither the government nor the drug companies want to tell us. And when you think that every time a celebrity or a politician has a sexual affair or sends an email or a text message, it is known in the media, makes a big story, you don't even know we are voting and we don't know what the price of drugs is, it's ridiculous. So About the price, initially at the time Cefalbivir arrived in Europe, the French government tried to bring the other government from the European Union to have a global negotiation and be stronger against the drug companies and Gilead at the time. And that was a failure. The Germans didn't want it, and at the end they had the highest price in Europe. And the Portuguese had the lowest price, and our government claimed they had a great deal and a fantastic price, but at the end it was not that fantastic. It was something like 45,000 for 12 weeks of treatment, euros. And that was not, I think that was not great, but again, I don't know what the real price was. So the price has been renegotiated, and now the AbbVie combo and the Merck combo are around 25,000 euros per 12 weeks, which is more reasonable, but still very expensive, I think. Our system is different from many other systems. France, thanks to our kings and the revolution, is a very centralized country. Well, the revolution killed the kings, but they kept the centralization, which at the end is a good idea. So we have one government, everything is decided centrally. We don't have different systems. We have one social security system, and HCV is 100% reimbursed by the French government. Whoever you are, whatever you do, if you have your ID card, if you don't have an ID card, if you're an immigrant, there will be a system to cover you and pay your treatment, which is great. So the government, I'm trying to make it short, but it's complicated anyway, the government has finally decided to make universal treatment possible. They promised it in May of last year. They opened the indication, not completely universal, in August. With what is written now in the law, you can treat everybody, even if it's not written like this, because you can always find a way by which you treat people. And they will announce universal treatment before the French presidential election. You probably heard about it. It's a big disaster, total disorder, but at least this government will have to end up at some point, so they will have to do it before they leave, even if we don't have a government afterwards. The final point I wanted to discuss is how hepatitis C treatment is delivered and prescribed. It's very different from the Australian system. We have a system of reference centers and networks around the reference centers. It can be a university hospital, a general hospital. It can be a clinic, but it has to be in the hands of specialists. These specialists can be hepatologists, they can be infectious disease, they can be internal medicine. We have some GPs, but they are specialized in hepatitis C, but it's certainly not open access. It's the initial prescription has to be made in a reference center, and then the follow-up and monitoring can be done anywhere. Obviously, the situation is different here in Canada or in Australia. We have more inhabitants in France, but the country is much smaller, and everybody is close to a reference center. So it's easy to see a doctor, have your initial prescription, and then be followed elsewhere. I think it's a very reasonable way to do it. I'm probably biased because I come from a country where this is the way we do it. I'm not sure giving access to the full prescription to general practitioners who see very few patients is a great idea. I have one anecdote which happened to me in this country when I was visiting in May. And I told you I was taken to give a lecture in a small clinic in Ontario. Very nice people taking care of HIV patients. And I gave my talk and we had a great discussion. I just realized that they had HIV patients. Some of these patients had cirrhosis. They were very much able to treat their hepatitis C. And what did they do after that? Send the patient back to the general practitioner, not do anything in terms of liver disease, follow-up, monitoring of HCC, complete ignorance of what had to be done. I hope my stay with them a few hours was helpful, and I tried to explain to them what to do, but I'm just afraid that at some point, treating hepatitis C is not the issue. The issue is being able to diagnose the severity of liver disease and make sure that patients will be properly managed and followed after treatment, which will be successful in the vast majority of cases. And in that respect, being seen by specialists initially is probably a good idea. This is more or less what I wanted to say. It was a bit long, I apologize.
No, I think that's perfect, Jean-Michel. That's exactly what I was looking for. And maybe I'll throw it, sorry to go back to Greg, but Greg, given Jean-Michel's concerns, this is obviously GP prescribing has been, quite a large uptake in Australia. What are your thoughts in terms of initial experiences, and how has that been managed around sort of making sure that people are linked to a specialist and whatnot?
I think there are a few sort of key issues that need to be addressed. Jean-Michel talked about the staging of liver disease, and we have a fair few FibroScans in Australia, but not enough to provide, obviously, primary care-based access. So our guidelines say that if you don't have access to FibroScan and you're at the primary care level, you do an APRI score. And if your APRI score is less than 1.0, you can treat as pre-cirrhosis. If it's greater than 1.0, then you refer through to get further staging or refer through to a specialist. If you're in a very remote area and you can't get staging done beyond the APRI, then treat as cirrhosis. You're over-treating a proportion of people with an APRI score of 1.0. But I think it's a reasonable sort of compromise, and I think it's working quite well. We can look at the data in terms of what the general practitioners are prescribing, and based on, as I said, the 24-week of soft declatosphere versus the 12, they're treating a very small proportion of people with cirrhosis. So they're largely treating people with pre-cirrhosis. So look, we need to look at what the outcomes are in the different sort of settings. We need to continue those mentorship and education programs. But I think there's a real sort of thirst for a group of people, particularly those that have high caseload. They're methadone prescribers, have a lot of general practitioners prescribe methadone. Those that have had sort of sexual health physician backgrounds, and obviously HIV prescribing sort of backgrounds. So they're sort of ready-made sort of cohorts at the primary care level that are keen to sort of get involved.
It's really interesting that you say that, Greg, because I've actually been having discussions here with colleagues in Canada. Jordan and I actually were chatting about it last night. And, it sounds like the people are really not sure about the willingness of GPs in Canada, particularly in drug and alcohol settings, or GPs in general, to get involved. And so, Jordan, I'd be really interested to hear your thoughts about what your experiences have been in sort of that regard.
Yeah, so I think it's very variable. I mean, and I don't by any means I don't think, I can talk about my own individual experience, but I do think that obviously there's a huge amount of variability across the country. There are some primary care practitioners, both nurses and doctors, who have been very engaged and really interested in taking up Hep C care. That being said, our experience in the Toronto area has been that not that many. We thought there would be a lot more interest, particularly among, as you said, methadone providers and other providers that may see a fairly large number of hepatitis C infected individuals. And to be honest, when we started our ECHO project, we haven't had as much uptake as we expected. And when we've been doing provider education symposia, our experience is that with a fair bit of advertising and polling, we get people to come. But if we actually look at the numbers that they treat, of individuals that they treat after these symposia, it's very low, even with a continued mentorship and support from our site. So I am, interested to know, I guess, whether we're doing something wrong, which we probably are, whether other people in Canada have had different experiences. But I also want to ask Greg another question about the data collection, because the thing that impresses me is that in a country that actually is not like France and is more like Canada in the sense that it's healthcare is a state-run issue, how have you been able to collect national level data on prescribing, all this prescribing information that we just simply can't get here?
So in some respects, we're more like France in that we have one payer. So the evaluation and the sort of the approval and the sort of payment for the therapeutic programs is all centralised by the federal government. So anything that's on what's called our pharmaceutical benefit scheme that's government subsidised, that information is collected centrally. So we can get individual level data in terms of the regimen, the duration. We're going to be looking at data in terms of completion, because we can know at least whether the 3 months has been dispensed, for example, and those have been planned for 12 weeks. So we'll be looking closely at that sort of data. And then we can look at retreatment sort of data, because we can link, obviously, at the individual sort of level. So it's having that sort of centralised sort of data. Obviously, we don't get the outcome, but that's why we're looking at setting up the registry for real-world outcomes. Just one thing about going back to the GPs. The data set also gives us the capacity to look at how many prescriptions GPs are making. And in New South Wales, the state where I work, 400 and something GPs have written at least one script in that first several months. Now, a fair few of them have written very few scripts, but 20% have written more than 10, or for more than 10 patients. So I think we will build up this cohort of relatively high caseload sort of GPs that really will become very experienced, and hopefully they'll help mentor other sort of general practitioners and spread the word, so to speak.
Yeah, and there's two other things that I kind of wanted to add to the discussion. So the first thing, to add what Greg said, the Australasian Society for HIV, Viral Hepatitis, and Sexual Health Medicine has been doing, as Greg said, education and training workshops for practitioners working in drug and alcohol settings and in general practices in rural areas, urban areas. They've done something between, I think they've said, since the DA started, somewhere between 100 and 150 workshops across Australia, sort of either evening sessions or full-day sessions to train up providers in that setting. The other thing I wanted to touch on quickly is Jordan. We were discussing last night about this and sort of, why, GPs perhaps might not have been as engaged in Canada as they have in Australia. And I think part of the problem potentially also lies in the restrictions. So if you're restricting people to F2 or greater, and as Greg said, there's already this triaging happening where there's individuals with an APRI less than 1. They're treating the easier cases. So just by the nature of the restrictions, it's actually causing an artificial restriction around prescribing and who is going to prescribe. So I would hope that next year, once the restrictions remove somewhat around sort of fibrosis stage, then that might open it up and more GPs, and particular GPs that are higher caseload, working in drug and alcohol settings, sort of might be interested in getting involved. I want to shift over maybe to Patricia to provide a bit of a community perspective, and I'm really interested to hear sort of listening to what's been going on in Australia, and I'm not sure in terms of the community response. You're very involved in terms of the work that Action Hepatitis Canada has been doing here in Canada. What are your reflections in terms of what's been going on in Australia, and do you have any sort of insights around how complicated it's been from a community perspective to try to get engagement from the government and from sort of various people on that side?
Yeah, that's a great question. It's a big one too. Thanks for the question. I think with Canada, I think what we're really looking at is it's a bit of a good news, bad news story, and I'm just wondering what people want first, if they want the good news or the bad news. Why do people have good news first?
Good news first.
Good news first. Well, the good news first is that Canada is in a fortuitous position because there are other countries who are a lot like us who have come before us and have already got strategies and are in second generations of their strategies and that sort of thing. And it means that we have an opportunity for learning, and we don't have to work from a blank slate. And that is really good news, because I think strategies and working towards elimination is a massive undertaking that takes a lot of coordination and effort across the country. And so we can look to places like Australia and Scotland and France as well to look at what they have done and managed to achieve, and we can do that too. It is bad news too, though, because we have to be really mindful that we have a very unique federalist system that is unique to Canada and creates some particular challenges that are ours alone to have. And it does make things more challenging for us to get things off the ground in terms of having a strategy or an action plan. And I think the reality for us as groups that are trying to advocate for change and to create better treatment for all in Canada is we do need a plan, we need a roadmap, and so we are looking right now at an action plan or strategy. I know there's some issues around language these days that we can't say strategy anymore, so I believe now the new word is action plan. So great, let's get some action. Let's get a plan with some action. But so we do. So we can look at some of the things that are going on in other countries. We can certainly take out and tease out those common elements that we've seen when we look at all of these other strategies that are going on. We see some very common themes and elements that they have in there that we should definitely be putting into our action plan. Issues around surveillance that came up a lot today in today's talk as well. We know our surveillance data is not where it should be, and we can do better. And other aspects that are in several of the strategies are around addressing stigma as a principal contributor to infection, addressing social inequities. It's great to have an idea that we want to eliminate by 2030, but if we don't address social inequities, we are going to be, we will continue to fail. We need to set population-specific approaches, and we need to increase, and we need to set some very specific targets. And I think without targets, without saying we're going to increase the number of people that we're going to treat by certain numbers every year, we're not going to get where we want to go. And we also have a very challenging healthcare system to navigate, and it's very difficult to navigate around in terms of our advocacy efforts. Certainly at Action Hepatitis Canada, we've been struggling around not only where the policy gaps and challenges are, but it's who on earth are we supposed to talk to about this? And when we talk to the feds, they say, well, that's really a sort of a province and territorial issue, and you got to go talk to them. And then when we go and talk to them, they say, you need to, we need federal leadership, and then back off. So it's been really a challenge, and trying to figure out what levers to push in terms of getting the policy changes that we want so that we can actually create what the title of this panel is called, which is Access for All, has been a challenge. And when I think about people at Action Hepatitis Canada who are learned, smart people who have all the tools they need to try to figure out a system, and we are struggling to figure out a system to create the right kind of change. I think about a person who's in a remote or rural community who has Hep C, who maybe hasn't had the opportunities around education or around access to basic health care, and they're trying to navigate that same system. And it is a mess. And so I know we can do better. And I think the first step to doing better is we do need an action plan or strategy, whatever we want to call it this week, but we do actually need a roadmap, and it needs to have leadership and a coordinated effort behind it.
That's great. Thank you so much, Patricia. That's really wonderful. I think that provides actually a great segue into Mel. Now, I think Mel had about 3 or 4 quick slides that he wanted to sort of guide his discussion. So, Mel, maybe you'd like to kind of pick up from what Patricia was saying, because I think it's kind of related to what you wanted to touch on.
Thank you, Jason. Thank you, Patricia. So, I don't know if everyone has seen this, but this is the news release from BC as of last week, which basically has the points that were highlighted by Greg and others, that the pricing is confidential, probably a similar kind of model to Australia. The drugs that are soon going to be reimbursed are listed, and essentially by March 2017, everything will be, in BC, it'll be fibrosis with virtually any comorbidity, and by 2018-19, it'll be fibrosis independent. And you've already had most of the other discussions. But I want to show you this slide, and it's a very important slide that comes from our hepatitis testers cohort. So you could argue what a baby boomer is and when they start, when they finish, but at the end of the day, between 2/3 to 3/4 are baby boomers in terms of the people who are tested. In blue and green, you see the amount of testing that we've done in British Columbia. And then if you look towards the end, you'll see that in the people born after 1980, there's been a lot of testing, single tests, multiple tests, and it's consistent that essentially the bulk of the population are in fact baby boomers who have liver disease. What's important to understand is because these baby boomers got infected before the cohort was actually created, and the testing only occurred in the early 90s, it means we have not been able to account for their acquisition risks. And we can argue what those acquisition risks are, but they're not measured. On the other hand, for the people who were born in the 70s, and in green you have the seroconverters that we can measure, those people we can measure acquisition risks as well as what the virus is doing. If you look at the next slide, a very important point, and Mark showed you this figure without the red, but if you look at the median age of the people who died, they were 74 years old. If you look at the median age of the positives, they were 55 years old. That's a lot of life that people are losing. And if you look in terms of what's in the circle, part of those deaths are because of acquisition risks and not necessarily the virus. And it's an important point that Patricia made, that access means more than just dealing with the treatment, and I'll talk about that in a second. If you look at these slides, it just differentiates the fact that in the boomers using the 45 to 64-year-old cohort, they're dying from cancer and liver disease, and accidents is down towards the end. But if you look at those born after 65, accidents, intentional self-harm, ill-defined points. So those slides are really about highlighting some points that came out of this meeting. So from an Indigenous perspective, our Indigenous colleagues highlighted that treatment by itself is not a panacea, and that's true. If you heard the point that Mark Tyndall highlighted, it was, if you use a public health perspective, it's really about promotion of health in its broadest sense, and it's not just about treatment. And we're going to have treatments. And because we're in Canada, we're going to have 10 provinces and 3 territories with variations of how those treatments are going to be released and funded, and access issues. The big question is access. And access is not just about treatment. It is about equitable access. That's the point that Patricia brought up. And it's really about broad access to the services that promote health, and treatment is just a piece. And as Greg Dorr highlighted, we need different models of care because one size doesn't fit all. Thank you.
Well, I actually can't even think of a better way to end the conference than on sort of those final words from Mel. So why don't we leave it at that? There's posters that are coming. Thank you, everyone, for even with the delays. Oh, I'm so sorry. Dr. Terrell is going to close the conference. I'd forgotten this. And that's why you were telling me times 6. Okay, now I understand. I'm sorry. Dr. Terrell is going to close the conference as the convener with his co-convener, Dr. Carla Coffin.